Welcome to the Pupil Pod, where we use clinical cases to guide discussions of board-reviewed topics. I'm your host, Sila Bal, and my guest today is one of my mentors, a dear friend, someone I look up to, Dr. Neda Shamie. Dr. Shamie needs no introduction, as most of you know her already, but she is a cataract and cornea surgeon and partner at Maloney Shamie Hura Vision Institute. Dr. Shamie, thank you as always for joining me today.
Thank you so much for having me. I love this podcast, and you know how much I love you and inspired by you. And what you may or may not know is I've told my daughters that you have to follow Sila Bal on her social media because I'm trying to, through you, convince them to go into ophthalmology, and I'm going to have them listen to this podcast too, and that'll be further hopefully influence on them. To follow the path that you and I have followed and loved. So I appreciate you doing this. It's such a valuable resource for the next generation of ophthalmologists.
That is the highest compliment. I mean, the further I get down this path, the more I realize that I'm actually getting old and I'm not as cool as I thought I used to be. So that's definitely a humbling experience for me too.
You can be old and cool. You can be old
Yeah,
and cool, Sola.
cool age. I met somebody that was 80 once that I thought was just the coolest woman I had ever met. So that's my goal. That's my bar that I aspire to hit, that 80-year-old cool.
Yes.
So, today's episode is going to be a little bit different than our usual content. I'm not really presenting a specific case, but we're going to treat this as if I am calling one of my mentors and I am just like, I'm exhausted with treating astigmatism. I really want to get it right for my patients. I want them to have the best possible vision in the future. Calling my mentor and saying, can you please walk me through those tough cases, the cases where I don't know what to do? So, Dr. Shamie, can you share some insight into common astigmatism correction techniques that you use in your practice and maybe some of the ones that you used in the past that you're not necessarily using anymore?
I think what's important to note is, you know, I've been in this now for 20 years, and when I first started doing cataract surgery, you didn't even think about these kinds of refractive outcomes. You just exchange the natural lens with an intraocular lens, and then the patient would go off and expected to wear glasses and such. But we know that as little of half a diopter of refractive astigmatism can impact the visual outcome, and more patients are expecting more than just clarity of vision with cataract surgery. They want optimized vision and they want freedom from glasses if possible, as much as possible. And so addressing astigmatism is absolutely part of the process of cataract surgery. And how does one address astigmatism? And this is specifically corneal astigmatism, because as we know, a patient who has cataract, some of the astigmatism may be lenticular, but you're removing that cataract, and with it, you're going to remove lenticular source of astigmatism. What you're looking at is you want to make sure that I guess we'll get into this later, but you want to make sure that what you're addressing is the corneal astigmatism, which will translate into refractive astigmatism. And that's by looking at their keratometry, their topography, and then assessing that. And so there's different ways of addressing corneal astigmatism with cataract surgery. Limbal relaxing incision or arcuates with femtosecond laser are the corneal based approach. Typically that's for lower correction, and we'll get into details of how does one choose one versus the other. Toric lenses, thankfully now with almost every lens platform, there's a toric version. Before, we used with multifocal lenses, for example, toric was not available, but now the multifocal lens options have toric correction. And then monofocal, of course, there's all different types of monofocals, and they typically come in toric versions also. And LASIK adjustment or LASIK enhancement post cataract surgery is an option that's usually used more for the multifocal patients who you may have missed the astigmatism correction and you want to fine tune it, or monofocal. So these are all the different techniques, and we still use them. I mean, I think LRIs were ones that I started off with, and then when torics became available, I was definitely one of the first ones to implement that in our practice, thanks to my mentors who valued the importance of optimizing the refractive outcome from cataract surgery, not just clarifying the vision.
So, you mentioned LRIs. When I was a resident and a fellow, I learned how to do LRIs and we did a lot of LRIs, but now I just don't really use them in my practice anymore. I'm mainly focused on arcuates with my femto or toric lenses. Are you still using LRIs? What are kind of your preferred methods? Is there one astigmatism correction technique that you go towards over another?
I mean, LRIs, I use them, we call them more AKs for PKP patients and such. So I agree with you. Manual LRIs are, I rarely use in my cataract patients because 98% of my cataract patients choose to have femto cataract, and I much prefer arcuates with femto. It's a much more precise placement. It is now with image guidance, it's right on axis where you want it to be, and it's exactly the length you want it to be, the depth you want it to be. So manual LRIs are don't feel as precise as you would like. But I have used it in a patient who can't afford femto cataract surgery, and I feel, and they can't afford toric, and I feel that I want to debulk their astigmatism some, so I just do it without cost for the patient. And I use a diamond blade and use various different nomograms and such, and do it. But it's extremely rare that I'm now it's extremely rare that I'm doing manual LRIs. Having said that, not every surgeon has access to femto. And so I think it is a skill that every surgeon should have up their sleeve, because why not? Why not debulk that astigmatism for patients who have regular astigmatism? And again, even if they don't afford it. Now, there are surgeons who charge for manual LRIs, which is, I think, is absolutely reasonable because you are doing a refractive procedure for that patient. And as we also know, femto is kind of, it's approved if you are charging the patient. It's approved for astigmatism correction. So you have to do an LRI if you're not using a premium lens. As far as what my preferred method is, it really depends on the amount of corneal astigmatism the patient has. And when we talk about corneal astigmatism, I'm assuming here that we're talking about regular astigmatism, not irregular astigmatism. And that's based on topography, bow tie pattern. And then you want across different diagnostic modalities that there's similarity in both axis and amount of astigmatism. So assuming all of that and the ocular surface being healthy, depending on how much astigmatism the patient has, I then lean more towards toric versus arcs. If the astigmatism is less than 1 diopter with the rule, I tend to go towards limbal relaxing incisions or arcuates with femto. Um, if it's more than 1 diopter with the rule, I tend to lean towards toric. Now, if it's against the rule astigmatism, then it's usually 0.75 or lower is limbal relaxing incisions, and more than 0.75, I go towards toric. Why does that different with the rule versus against the rule? We know that posterior cornea contributes to the astigmatism, and if it's with the rule, when you're assessing the surface cornea, the posterior cornea actually lessens the astigmatism some. So there is about a 0.25 up to even zero point 0.5 lessening of the true measured total astigmatism for that eye. And if it's against the rule, it usually adds to it. But now with advanced diagnostics and nomograms and ways that you can plug in these numbers, you kind of can be brainless about it and really follow the lead. We use Veracity, and we input all our information into Veracity, and it also captures a lot of the information, and kind of without me having to think about it, it gives me guidance as to which option would be best. What you want to try to avoid is, with a toric lens, you want to avoid flipping the axis, especially if a patient is with the rule. So be careful about that when you're looking at the toric calculations. If it flips the axis, it's got to be less than 0.25 if it's going from with the rule to against the rule of a flip axis. So that also helps for those patients who are hovering between numbers where you're thinking, should I go with arcuates versus torics? One last thing. I personally, being a corneal specialist, dealing with patients who've suffered from severe dry eyes as a result of corneal incisions and such, I don't like to go more than 30 or 35-degree of arcuate incision. There's no science behind that. It's just that I have seen patients who have had really gigantic LRIs. The surgeon thinks that they're doing this patient a favor. They put a 45-degree arcuates, paired arcuates, and this patient then suffers from neurotrophic keratopathy and severe ocular surface disease as a result of the severed nerves. Or I've also seen ectasia as a result of very large arcuates that were placed. So my personal cutoff is 30 to 35. And so 30 definitely. And then sometimes I push it to 35 degrees.
So much important information there. I had a patient recently where it wanted me to do, I think, like a 50-degree arc. And I just sat there staring at the machine thinking there's no chance I'm doing this. So I just didn't do it. And I'm glad I didn't. But you have to be careful. You have to double check your work. And then the other thing I wanted to circle back to was flipped axis. I'm still at that stage where if even if it's going to leave me with zero point 0.4, zero point 0.3, zero point 0.4 diopters of SIL, I will go for right above where it flips the axis and just leave them with a little bit of sill rather than risk any flipping of the axis because I just don't want an unhappy patient. And I think they'll be less unhappy with some residual sill than they would if I flip them even a little bit.
If you're going from with the rule to against the rule, my experience has been against the rule patient, especially if you're doing bilateral surgery where both could potentially be flipped. But if it's less than 0.25 of a flipped, if they go from against the rule to with the rule, they're made less unhappy. But a with the rule patient going to against the rule, I agree with you, tends to be very unhappy. And I think it's because the with the rule astigmatism gives you some depth of focus for those patients. And they tend to, at least that's kind of been my experience with patients.
Oh, that's so interesting. I'm writing this all down so that I remember to think about it a little bit more clearly. But maybe I'll try it on my next against the rule to with the rule patient, see what happens if I flip their axis a little bit, or at least give them that first line with flipping the axis, the less sill. So I know that you are using a lot of femto. So most likely you're marking your torics with your femto. But before you were marking with femto or in those patients where you're not doing laser assisted cataract surgery, what was your marking strategy? Were you doing manual markings? Were you using the Callisto? Do you have any insight onto best techniques for the most accurate results? Some people do it at the slit lamp. And then for our younger learners, so our medical students, our first year residents, why are we even marking before we go into the OR? Why not just mark when we get in there?
Yeah, no, the great question because, well, we know that when patients are sitting upright versus laying supine, there's excyclotorsion. And so you can't go by marking the horizontal when they're lying down because that will not match their upright rotation of their eye. And so it won't match their refractive astigmatism or corneal astigmatism as was measured pre-op. So when you're measuring them at the diagnostic tools that you have in your office, trying to decide what axis their astigmatism is, they're sitting upright. But when they're lying down, there's cyclotorsion. I mark, I still do this. I manually mark. It. I used to have them come to the slit lamp and I'd mark it at the slit lamp. But truthfully, I found that that was not necessarily a lot more accurate than me marking at the bedside, having the patient sit up, rotate their legs off the bed, and they're sitting upright much like what they do, when they're sitting behind the topographer or an IOL master. So they're upright, and I mark the horizontal axis, and I put two marks right at the limbus. Now there's but I'm much more confident doing that now because I also have femto and image guidance. With femto, I use the Lens AR Ally, which has an incredible streamlined way of taking the images done off of our IOL Master or Pentacam and matching the axis and placing nubs on the capsulotomy to allow for me to know exactly the axis of the toric. So I still do the manual in case that fails me, but I'm less reliant on my manual. I also have Callisto, which I think is an incredible way of, again, taking the images pre-op, looking at the vessels and matching the vessels to the image when the patient's supine, and making sure that you compensate for any excyclotorsion, and then also intraoperative aberrometry. So I thankfully I'm blessed to have access to all of this very advanced technology. Um, my manual is definitely the least accurate, but surprisingly, I've double checked it with Callisto and the intraoperative aberrometry and even the femto. It's not terribly off axis, but as we know with toric, for every several degrees being off axis from where your toric alignment should be, you lose the effect of the toricity. So being accurate in marking is really critical. So what's my preferred way? I'm loving the Ally right now and the Ally femtosecond laser. And again, the way it takes the image from preoperative evaluation of the patient while they're upright, and then converts it into nubs on the capsulotomy such that I know visually know exactly where to place my toric. And then I double check that with my Callisto as well as intraoperative aberrometry in any patients I have. I'm concerned about whether or not there was accuracy between images. But if I could rely on just one tool, it would be the Ally nubs.
No, I feel the same way. We use the Catalyst femtosecond laser system, and we also have our nubs are actually on the cornea, but it's just so accurate. You feel very confident. I've double checked it with intraoperative aberrometry, and it is right on the money, right where I want it to be. With Callisto, sometimes I do struggle. So, for the residents and fellows out there, sometimes with Callisto, it doesn't line up directly where I want it to when I have it on in the operating room. But so then I get a little bit nervous. So when I'm using Callisto, I always manually mark. But when I'm using the Catalyst or my Femto, I'm not always manually marking, to be honest, because I trust it so much. Maybe I should go back to manually marking those cases. But with Callisto, I always manually mark because I need that reassurance that I'm actually putting the lens where I wanted to initially put it. So
I think it's good to manually mark because sometimes, sometimes you may not be able to get it. Exactly.
So, before we get into our next question, I just want to remind our listeners this is an independent podcast. Neither Dr. Shamie nor I are saying these things because we're getting any kickbacks from these companies. But, Dr. Shamie, do you have a preferred lens platform when you go for toric? So, like, is there a monofocal toric lens that you tend to reach for more? Is there a multifocal toric that you tend to reach for more? Is it just the same platform that you normally use? Do you notice any difference?
Yeah, I mean, there were some studies previously with some platforms having less rotation of the lens post-op than others, but that's not been the case with it was early on with toric lenses that I think there was one study that showed that Alcon lenses did better, but that has not been the case anymore because the other lenses changed their haptic design to make it so that the toric lens doesn't rotate. And my experience has been I go with the platform that I think optically will offer the patient the outcome that I'm seeking for that patient. And it's less about which toric is better. So if I think the patient would be a great PanOptix Pro patient, I'm not thinking is the toric in PanOptix better than the other multifocal lenses, and so that's become less of a deciding factor for me. I'm just going with the optics of whatever monofocal or multifocal lens I think would be right for this patient. And I would urge everyone to do the same. Just think with or without astigmatism, what would you choose for this patient? And then make sure that you address the astigmatism, whether it's with arcs or LRIs, or a toric version of that lens.
Great. So, speaking about different lenses and different platforms, what about patients with irregular astigmatism? So, up until this point, we've really been addressing regular astigmatism. I had a patient with, I want to say he had 3 diopters of irregular astigmatism from a large corneal scar. And there's certain lens platforms like the IC8 that advertise up to like 1.5 to 2 diopters of irregular astigmatism. But I ended up using the IC8 and he was thrilled. He was 20/20. He went from 2100 to 20/20 post-op day one. So there's a little wiggle room there. And if you have the right patient and they're motivated and you give it a try, there's some things that we can work with for our irregular astigmatism patients. So what are some of the things that you like to offer those patients?
Yeah, I mean, the irregular astigmatism patients in my practice commonly are either keratoconics, ectasia patients, or post PKP patients. I mean, there are irregular corneal patients as a result of things like EBMD and dry eyes or Salzmann nodules that you need to make sure you address before you do the cataract surgery, and so that's a whole different side topic. But let's say the irregular astigmatism is a keratoconic. There's a couple of things that you need to think about. First of all, it could be irregular when you look at the whole global topography of the patient, and irregular meaning that it's not a bow tie, it's not symmetric from, you know, when you cut the cornea into half. And this is how I speak to the patient when you look at the cornea, half on this side versus the other is an equal size of the pie that's being highlighted with the topographic steepening. And so if it's irregular and when you look at the topography on a global scale, doesn't necessarily mean that that patient can't have a toric. You have to look at that central 3 millimeter. And if that central 3 millimeter is mostly bow tie, and as we know, some of these keratoconics are such, the central 3 millimeter on the topography is bow tie, but then the steep belly of the keratoconus is outside of that central 3 millimeters. Well, in that patient, you also look and see ask them or look and see, do they get reasonably good vision with manifest refraction, or had they in the recent past before their cataract got worse get reasonable refractive vision uh, with just manifest refraction with a cylinder that somewhat matched the amount of refractive cylinder that they had. Let's talk about the keratoconic patient who has irregular astigmatism on corneal topography, but you look at their global topography and they have this big belly of the cone inferior, but their central 3 millimeters is mostly bow tie. So, what you want to then look at for that patient is, did they, before their cataract formation or even now, does their refractive manifest refraction or their refractive astigmatism, I'm sorry, does it match their topographic cylinder? Just about. So, do they have like 3 diopters of astigmatism when you manifest them, and the axis and the amount of astigmatism is similar to what they have on their topographic central 3 millimeters? And then also, do they share with you that they've managed okay with glasses? So that patient actually could do quite well with a toric lens. And I wouldn't just discount the fact that, you know, they're keratoconic, so we can't do toric. We have to go straight to IC8, because I've gotten in trouble with that. I had a patient who was exactly that, and I did IC8, and they still ended up having 3 diopters of astigmatism post-op, and the IC8 sure improved their vision some. So I ended up exchanging it with a toric to treat their full astigmatism, and they were ecstatic. So again, pay attention to that central 3 millimeters. If it's a patient who's like a post PKP patient, it's a similar concept. Again, is the central area mostly regular? Then you can do a toric, monofocal toric. Don't venture out and get too aggressive with multifocals and such, but a monofocal toric could work. A light adjustable lens could work. And that's important to note, is that the light adjustable lens treats up to about 2.5 diopters of astigmatism, but it has to be regular astigmatism. So light adjustable lens in an irregular cornea will not deliver the results that a patient who's investing that amount of money and time deserves. So I would not do a light adjustable lens in a highly irregular cornea. I would consider it in an eye that you would consider a toric lens in, but it has a more precise way of correcting the astigmatism. One other comment about that: the problem with light adjustable lens in patients who have 2 to 3 diopters of astigmatism is that until the patient starts getting adjusted, they're going to be miserable, because you're not treating their astigmatism with that initial surgery, because the light adjustable lens in its virgin state is a monofocal lens. It's not a toric lens. So I still lean towards, mostly for those patients who have higher astigmatism, toric, even if it's irregular, as long as the central is bow tie. The IC8 is a wonderful option for the irregular corneas, and it also can help debulk. So even if a patient has 5 diopters of astigmatism, and it's irregular astigmatism, the IC8 can help debulk it. But I would suggest maybe considering doing an LRI or an AK if it's a PKP patient, not an ectasia or keratoconic. But if it's a PKP patient, debulking the astigmatism with LRIs to see if you can lessen it before you do any cataract surgery for these patients. And um, uh, I just actually did cataract surgery on a patient of mine. I did PKP on a year and a half ago. He had 5 diopters of astigmatism. After PK, I did LRIs, lowered it to 3, and I just put a toric lens for him. And he just texted me saying his vision is better than it's ever been in his life. His son is actually an optometrist who's seeing him, has 20/50 vision uncorrected post-op day 1. So this is someone who has had this long journey. But again, LAL IC8 is a wonderful option for irregular, but you got to lessen the astigmatism as much as you can, if you can, with AKs. Lastly, there are those irregular astigmatism patients who are reliant on gas permeable contact lenses. Those just do a non-toric and get them, get them back into an RGP.
So interesting. The PKP patients are always really challenging, especially because I feel that their astigmatism, even after you're done with suture removal, really tends to fluctuate. So they can be a little bit daunting for the younger surgeons when we're approaching their astigmatism correction. Okay, so speaking of daunting, let's say that you have a patient that has a toric lens that had residual astigmatism. How do you assess those patients? Like, what would be your approach? How do you assess for undercorrection versus whether or not the lens was rotated? And then once you identify the problem, how do you deal with those patients?
Yeah. Well, first you want to make sure the ocular surface is perfectly optimized. You want to double check the topography to see if it matches the pre-op. Sometimes if your incision or LRI was too big, you could have shifted the astigmatism such that their pre-op doesn't match now their post-op. And then if you have those nubs on, whether it's corneal incisions that allowed for you to kind of mark where the axis is, uh, or capsule nubs, you want to dilate the eye and look and see if the toric is aligned where you had intended it to. And even if you don't have the nubs, look at it at the slit lamp on a dilated exam to see if the toric is aligned where you had planned it or initially placed it. And so you'll know if it's rotated, if it's off that axis that you had initially placed. But a great way to know is astigmatismfix.com is John Burdall's software that he created. It's a wonderful program. You plug in all the numbers pre and post op, and then it tells you if you were to rotate the toric, what would be your residual astigmatism versus exchanging it. So it kind of makes it really easy to decide if this is a toric that can be rotated back into position, or do I just plan on enhancing or even exchanging it if it was under or over corrected?
So, just to summarize what we've discussed, how do you approach astigmatism and astigmatism correction with your patients to ensure that they have the best refractive outcome? So, when you're talking to a patient, let's say I walk into your clinic, I have 3 diopters, regular astigmatism, I'm really motivated. How do you kind of approach these patients so that they have appropriate expectations postoperatively?
So a cataract patient, otherwise healthy eyes, and they have 3 diopters of astigmatism. I mean, it's a very easy conversation if the patient is interested in premium lenses. If they are interested in having freedom from glasses, then the astigmatism conversation doesn't even have to happen if I'm talking about multifocal lenses, or I'm talking about extended range lens, because it's embedded in that conversation. So I don't even touch on the astigmatism correction in those patients. I just focus on talking about multifocal or extended range lens. But in it, I do say that our goal will be to do what we can to optimize your vision so that you're on target. If it's a patient who's not a candidate for a multifocal or extended range lens, then the conversation is slightly more difficult, but not so much if they have refractive astigmatism, because they know the term astigmatism. A patient who's wearing toric contact lenses or has astigmatism in their glasses, they get it. So I say your eyes shaped like a football, and it ideally it should be like a volleyball, and the light, when it passes through your eye, the light rays are elongated in one direction and shrunken on the other side, and it distorts the vision. Unless we put a lens that cancels that effect, you're going to have to wear glasses. Otherwise, you won't be able to get optimized vision. Um, the challenging patients will be the ones that they have corneal astigmatism that's been canceled by their lenticular astigmatism. So their refractive error in their glasses and contacts did not have that much astigmatism, but you see that they're going to have 3 diopters of corneal astigmatism that's going to get unroofed or become evident with the cataract removal. That's the most difficult conversation to have, because now you're telling them you have astigmatism. Well, I've never had astigmatism. That's when you have to kind of get into describing the light rays and, those mirrors that are distorted in the old circuses or festivals and things like that, that your eye is like those mirrors. And if we don't correct that, you're going to have distorted vision that you've never had before. And so you're going to struggle with the need for thicker glasses than you're used to. So it just takes a little more chair time. But I think the key is understanding as a surgeon how important it is to address astigmatism, and that delivery of your message will come with your own personal belief in the importance of this variable in your consideration of how you're going to optimize patient vision.
Absolutely. And this is why it's so important to talk to mentors, people that have been doing this for a long time, because I'm just thinking like there's so many things you said just now in your patient counseling that I'm like, oh, I don't say that. I don't say the fun house mirrors. I say the basketball and the football and the distortion of the light rays. But the fun house mirrors is such a tangible way for people to understand the distortion. So that's something that I'm going to try today when I'm counseling patients. Just explain the funhouse mirrors to them and see how they respond. They'll probably laugh. They're
Yeah.
so cute here,
Yeah,
but
let me know how it
exactly,
goes.
exactly. Well, Dr. Shamie, thank you so much. There is an incredible wealth of information in this episode. Astigmatism correction is essential for our patients' vision. It's essential for patient outcomes, but it's something that, there are nuances. We act like it's easy, but it's not always easy. There are really different ways to address it. And so I hope everyone can circle back to this episode from time to time as they need it. And thank you again for joining us on this episode of the Pupil Pod.
Thank you so much, Sila. This was a lot of fun.
And thank you to those tuning in. See you next time on the Pupil Pod.